So welcome to Cardiac Sciences Grand Rounds. I am not Andrew Howarth. He is working hard at South Health Campus saving lives, and so I'm here in his place. For those who know me, I'm Satish Raj. I'm proud today to have the honor to introduce our talk today on new approaches to an old disorder. Hypertrophic cardiomyopathy has been around for a long time. We've all been traumatized by it, but in the last couple of years, there actually have been some exciting new treatments. And we have two speakers today to teach us what to do. The first is Dr. Bobby Heydari, who I guess has more recently joined the Hypertrophic Cardiomyopathy Clinic. I think he has a lot more experience imaging it from the MRI perspective, and I think he'll share both some cool pictures as well as some insights on newer treatments or potential treatments. I guess it's still potential treatments, right? For hypertrophic cardiomyopathy medically. And when that fails, Dr. Kent will come in and tell us how he'll just chop things out to make it better. The latter approach, by the way, good for EP business because often pacemakers or defibrillators are the result. With that, I'll let Bobby begin.
Thanks so much, Satish, for the introduction. And you have both Dr. Kent and I today, so double trouble. And thank you for BMS for providing coffee and treats. So today we're going to talk about some of the advances in the medical and surgical management of hypertrophic cardiomyopathy. So just a brief outline, I'm going to begin by talking about HCM evaluation and risk prognostication, chiefly by cardiac MRI. I will provide some information about the University of Calgary LIBIN Hypertrophic Cardiomyopathy Clinic locally. And I will be talking about some of the novel direct myosin inhibitors, chiefly mavacamten. And then Dr. Kent's going to talk about some novel surgical techniques for myectomy. So unfortunately, hypertrophic cardiomyopathy does have a fairly high prevalence. Depending on the study and the region, the prevalence ranges anywhere from 1 in 200 to 1 in 500, with an estimated 15 to 20 million patients affected worldwide. If we apply those estimates to Canadian population data, we can see that across Canada, there are approximately 12,000 patients with diagnosed symptomatic disease and approximately 8,000 with asymptomatic disease. But unfortunately, we can see the vast majority of patients, likely over 170,000, actually have undiagnosed hypertrophic cardiomyopathy. One really important recent effort has been the NHLBI-sponsored International HCMR Registry. This is actually a prospective registry that's been conducted across 44 sites in 6 countries and has recruited over 2,700 patients. The University of Calgary is part of HCMR, and we've contributed approximately 100 patients. And these patients have really had extensive characterization of their demographics, echocardiographic variables, electrocardiographic variables, genetic markers, biomarkers, and cardiac MRI evaluation. We're currently awaiting the long-term follow-up to determine prediction of these variables for prognostication of adverse clinical outcomes. There has been a slight revision or modification to the morphological classification of HCM, chiefly the isolated basal septal hypertrophy, which is sort of the sigmoid septum, versus the reverse curvature variant, which is more of the classic asymmetric septal hypertrophy that tends to result in left ventricular outflow tract obstruction. For the University of Calgary or LIBIN HCM clinic, all of our new referrals are stratified into those patients with chest pain and those without chest pain. All patients do undergo both echocardiographic and cardiac MRI evaluation, but those with chest pain will undergo a stress CMR to further characterize microvascular ischemia or small vessel ischemia. The addition of the MR has a number of benefits. It can assist us with diagnosis by excluding phenocopies such as Fabry disease or cardiac amyloidosis that can mimic hypertrophic cardiomyopathy. For those patients who we are suspicious have an inducible outflow obstruction, we can go on to do exercise echocardiography, for which we have very good access at South Health Campus. It also assists with risk stratification by looking at certain morphological markers. And as mentioned, we can also assess for microvascular disease, which can often be the etiology of chest pain symptomatology. So looking a bit more closely at that, once again, cardiac MRI does provide more accurate ventricular mass, volume, and function. This is particularly also important for serial evaluation if we're looking for progression of disease, if the hypertrophy is getting worse or there's more extensive fibrosis. There are also a number of markers that we can examine, such as the presence and extent of late gadolinium enhancement. T1 mapping is providing some quantitative assessment of fibrosis. We can look at strain, quantitate the degree of mitral regurgitation, and look for systolic anterior motion of the mitral valve. We can characterize apical aneurysm, including the presence of thrombus or layered thrombus. And in addition, it can also help with examining the apical extent of hypertrophy and involvement of the mitral valve for surgical planning, as we'll hear from Dr. Kent a little bit later. So many of you are familiar with this data. This is a relatively recent meta-analysis looking at the presence of patchy late gadolinium enhancement, which is a surrogate MR marker for fibrosis in the myocardium. And we can see this is almost 3,000 patients with a mean age of 55, followed for 37 months. And the LG prevalence was approximately 55% of the combined cohort. And when we look at the pooled odds ratios for all-cause mortality, we see it's significantly increased at 1.8 for those patients who have late gadolinium enhancement. When we look at the outcome of cardiac death, we see that, again, the pooled odds ratio is significantly increased at 2.9. And lastly, for sudden cardiac death, we see that the pooled odds ratio is over 3.4. But it's not just the presence or the absence, but also the extent of the late gadolinium enhancement. So here, if we look at the proportion of the myocardium that's involved or has late gadolinium enhancement, we see that there's a graded increase in the adjusted hazard ratio for sudden cardiac death. So not just the presence, but the extent. And very recently, there was a nice study. It's a small study of approximately 160 HCM patients. And these patients were evaluated for the progression of fibrosis by late gadolinium enhancement. And we can see here that the two MRs were roughly 5 years apart, and that the mean rate of progression was about 0.5% per year. But the patients who had more progression of late gadolinium enhancement had a strong association with undergoing ICD implantation, deterioration of their ejection fraction, and heart failure hospitalization. So we can see here that even the progression of late gadolinium enhancement can be a prognostic marker. There's been a few publications recently about the importance of apical aneurysm. We now realize that the development of an apical aneurysm in hypertrophic cardiomyopathy is actually quite an adverse morphology. This is a recent meta-analysis of over 2,300 patients. And again, when we examine the pooled odds ratio for arrhythmic events, we see that it's substantially increased over 4. And for thromboembolic events, including stroke, we see that it's over 9. So this does represent quite a high-risk cohort. Recently, the Toronto group examined 170 hypertrophic cardiomyopathy patients, and they found that in particular, when the aneurysm size was 2 centimeters or greater, that these patients had a much higher event rate at 5 years. And this was the strongest adjusted predictor for both sudden cardiac death and stroke thrombus. And of course, with MR, we are very sensitive at looking at the apex to determine if there's an apical aneurysm and or layered apical thrombus. Global longitudinal strain is also a potentially important prognostic marker. There was also a recent meta-analysis of 14 studies in over 3,000 HCM patients, again with a similar mean age of 63. All of the studies used 2D echocardiography, and although they couldn't pool the studies due to significant heterogeneity, for the endpoint of ventricular arrhythmias and appropriate ICD discharge, they did find a significant hazard ratio of between 1.15 to 1.29. We were very fortunate that we had a local scientist who actually created a novel feature tracking tool for the characterization of strain from routine cine imaging that we conduct without gadolinium at the time of cardiac MRI. And actually, we were able to evaluate 51 HCM patients compared to 38 healthy controls. And not only did we find that GLS and strain was abnormal in enhanced regions of the myocardium where there was late gadolinium enhancement, we also found that non-enhanced myocardial segments also had abnormal strain, suggesting that this is a diffuse process through the ventricle. And it was particularly worse in those with more extensive late enhancement. We were able to apply this data to the HCMR cohort, and over 2,300 patients underwent comprehensive strain evaluation, and we looked at markers of abnormal GLS, and they really correlated with known abnormal markers in hypertrophic cardiomyopathy. Those patients with more extensive hypertrophy, lower ejection fraction, lower left atrial emptying functions, and more extensive late enhancement. And when we looked at demographic factors in elastic net regression, we found that there was also an association with female sex, who unfortunately often have higher mortality than males in hypertrophic cardiomyopathy, as well as both the reverse curvature and apical morphologies. Interestingly, there was also a very strong association between GLS and baseline NT-proBNP levels. And as we'll see from some of the mavacamten studies that I'll present in a moment, NT-proBNP may be a really important serum marker for disease activity in hypertrophic cardiomyopathy. As I mentioned, we do have a fair degree of patients who have chest pain symptomatology, and many of them do not have left ventricular outflow tract obstruction. We routinely conduct stress perfusion MR in these patients. We know from histological studies that unfortunately HCM patients can develop thick-walled, narrow lumen intramural coronary arterioles, so-called small vessel disease. And this really does serve as a basis for microvascular disease. We can see in this patient, there are extensive regions or dark areas within the mid and apical portions of the ventricle, which are quite consistent with very severe microvascular disease. And interestingly, particularly in non-obstructive HCM patients, these patients can respond very well to beta blockade and low-dose nitrates. This may be an important marker for risk stratification and treatment of symptoms, but unfortunately, we need more studies. There was a very small study just published this year in Portugal, 75 hypertrophic cardiomyopathy patients with approximately 30% being obstructive, underwent both stress CMR and 2D echo strain for global longitudinal strain. And interestingly, they had a very high proportion of patients who actually, unfortunately, had stress perfusion defects. They excluded epicardial coronary artery disease by coronary CTA. And interestingly, when they did regression analysis comparing hypoperfused segments to global longitudinal strain, they saw that there was a fairly significant indirect relationship, that the more perfusion abnormalities, the lower or more abnormal the strain. So when we kind of put this all together and examine the new AHA 2020 guidelines for risk stratification of ICD implantation for hypertrophic cardiomyopathy, we see that largely the change or addition are three variables that are predominantly imaging-based markers. This is the presence of late gadolinium enhancement by MR, systolic dysfunction with an EF of under 50% that can be characterized by MR or echocardiography, and the presence of an LV apical aneurysm. The former criteria that are in the older version of the AHA and ESC guidelines are largely demographic. So how do the AHA guidelines, the novel guidelines, compare to the historic ESC guidelines for risk stratification? Well, there have been two studies to date that have compared them. The first is a fairly large single center study from Tufts conducted by Dr. Marin and colleagues. And this was a cohort of over 2,000 patients that utilized the AHA criteria for implantation of an ICD. Interestingly, when they retrospectively applied the ESC criteria, they saw that unfortunately, the ESC criteria lacked sensitivity and missed a number of patients who either had appropriate ICD discharge or sudden cardiac death. And we see here that the sensitivity was markedly different, 85% versus 58%. Very similarly, a larger study done in Europe by Dr. Rowan and colleagues was multi-center, 6 North American and European centers, and they found that the historic ESC criteria missed about 30% of patients overall, but particularly in those with low ESC risk, it missed almost 40% of patients, suggesting once again that the novel AHA criteria is much more sensitive. If you sort of group most of the modern studies to determine how many ICD implants are required to terminate VTVF in one patient, the ratio is approximately 6:1. And that's really similar to IHD or ischemic heart disease prevention trials that have been conducted in the last 10 years. So next, I'd just like to pivot to the importance of genetic evaluation in hypertrophic cardiomyopathy that plays a much more common role as of late. So not only does genetics help us with evaluation of the index patient to rule out phenocopies, but it also helps to evaluate families, which is becoming a much more important component for HCM multidisciplinary care. Unfortunately, sarcomere mutations do not predict sudden cardiac death or future clinical course. We know that approximately in modern studies, 30% of patients will have a sarcomere variant or genetic abnormality, and the most common variants are myosin binding protein C and beta myosin heavy chain. This has now received a class 1 recommendation for genetic cascade screening by the new HA 2020 guidelines. And I think Dr. Hathaway here has a sort of a very nice example of a pedigree demonstrating exactly the utility of genetic cascade screening. So you may have an index patient that you're seeing in the clinic who undergoes genetic screening and is found to have a myosin binding protein C mutation. The patient has 4 children that can then undergo genetic cascade screening just for that mutation. 1 child does not have the mutation and therefore is reassured for life, does not require any serial testing, nor does that child's progeny. So if there's any grandchildren or future children, they do not require screening. Unfortunately, the other 3 children do have the genetic abnormality. And so these patients do need to undergo imaging evaluation to determine if they have phenotypic disease. You may ask, what is the penetrance of patients who are genotype positive but phenotype negative? Will they actually develop disease through their lifetime? We don't have extensive data on this, but there was one study of 285 adults and pediatric carriers or gene mutation positive that were followed for over 20 years. And at 15 years, the penetrance was almost 50%. So approximately 50% of patients may go on to develop phenotypic disease. Risk factors included male sex and an abnormal baseline ECG, and the lowest risk variant was for troponin I mutations. I think the importance of genetic cascade screening also highlights the role of multidisciplinary HCM clinics. So the benefit of the multidisciplinary clinic is it can address multiple facets of HCM care. This has now received a 2A level recommendation from the revised 2020 American Heart Association guidelines. And there was an interesting study just published this year from the Mayo Clinic. And they actually surveyed over 2,000 patients with HCM that were then discharged back to the community from the Mayo Clinic. And these patients were followed for a mean of over 5 years. And what they actually found was, unfortunately, these patients had a very high incidence of symptoms, cardiac-related hospitalizations, and cardiac-related procedures. Over 20% had at least one hospitalization, and over 25% had at least one procedure. And risk factors included female sex, exertional symptoms, and worsened NYHA class. And what the Mayo was suggesting is perhaps some of these higher risk patients should actually go on to be followed in multidisciplinary HCM programs, that they shouldn't just be discharged back to the community. And I think that's important because I do want to highlight our local HCM clinic, which I think is quite a fantastic clinic that provides really excellent multidisciplinary care. There are 4 cardiologists in the clinic, Dr. Peters, Dr. Coleman, myself, and Dr. Zhao. The lifeblood of the clinic are 2 cardiac nurses who are here today, Rosa Sandinata and Sarah Urton. They really organize all of the referrals and patient flow and really take marvelous care of the patients. We work quite closely with 2 electrophysiologists who have a keen interest in HCM and help us with determining ICD implants, Dr. Ilhan and Dr. Sumner. We work very closely with medical genetics and conduct genetic cascade screening on almost all of our patients who wish to undergo it. We're very lucky. Many Canadian centers do not have a myectomy surgeon, but we're very lucky, and we're going to hear from Dr. Kent in a few moments about actual myectomy, and he's been critical in treating some of our sickest patients. And then lastly, Dr. Vidya Raj at the Heart and Minds Clinic has also played a really prominent role. A lot of our patients, unfortunately, have mental health and psychological conditions. They're younger patients. It can be very hard to know that your heart is quote unquote abnormal. And oftentimes she provides extensive support for these patients. Okay, just moving on a bit here. I want to talk for a few slides about the importance of the new direct myosin inhibitor, particularly mavacamten. So mavacamten is a small molecule allosteric modulator of cardiac myosin. It essentially reduces some of the actin-myosin cross bridges. I thank BMS for this beautiful image here. Mavacamten did undergo FDA approval in May of 2022, and it just recently underwent Health Canada approval in November of 2022. And the first study that was conducted evaluating mavacamten was the EXPLORER study. This was a prospective randomized placebo-controlled trial of 250 HCM patients with LVOT obstruction and NYHA 2 to 3 symptoms. And their primary endpoint was essentially improvements in peak VO2 by cardiopulmonary exercise testing, and more importantly, improvement in NYHA class. When we look at the baseline characteristics, we see that there was fairly good balance between male and females. The mean age was 58, and that these patients were fairly sick. The resting gradient was over 50, the mean gradient and the mean post-exercise gradient was over 80. And interestingly, for the primary endpoint of improvement of peak VO2 and NYHA class, 37% of patients achieved this in the mavacamten group versus only 17% in the placebo group. But I think more importantly, what I'd like to highlight is if we look at the proportion of patients who reached NYHA1 or NYHA2 classification at the end of the study treatment period, we see that this is much higher for mavacamten versus placebo. In addition, if we look at the resting gradient, here we see the blue is mavacamten, the red is placebo, we see that there's a very early and sustained reduction of the resting gradient in the mavacamten arm. And this came without any significant or clinically significant reduction in the LV ejection fraction. Interestingly, when you put the serum NT-proBNP levels next to the resting gradient, we see that the reduction of NT-proBNP in the mavacamten arm almost mirrors exactly the reduction in the resting gradient. Once again, suggesting that NT-proBNP may actually be an excellent marker for disease activity. There was a small sub-study of EXPLORER that actually included cardiac MRI evaluation of these patients. It was only 35 patients, 17 in the mavacamten arm and 18 in the placebo arm. But very interestingly, what they found was in the mavacamten arm, there was quite a significant reduction in the degree of LV hypertrophy. Because by MR, we're able to determine the proportion of the myocardium that's actually extracellular matrix versus myocardial cells, most of this reduction was actually due to true myocyte hypertrophy reduction. So it's very, very interesting results, although it's a small population. We saw that in terms of maximal wall thickness, there was also significant reductions in the mavacamten versus placebo arm. This is the first data that suggests there may be a therapy that's actually disease modifying, that it could potentially reduce hypertrophy. Of course, I'm sure all of the clinicians in the room want to know, but were there lots of adverse events? And fortunately, the answer to that question is no. There were very few adverse events. In fact, there was no heart failure in the mavacamten group, fortunately, and only 5 patients had a reduction of their ejection fraction below 50%. And all of these patients actually normalized with their EF normalized with discontinuation of the mavacamten. The last study that I'll talk about today is the VALOR HCM study. So this was the second study of mavacamten that was once again prospective, randomized, and placebo-controlled. 112 HCM patients underwent 16 weeks of therapy. And these patients were actually quite a bit sicker because the primary endpoint here was to determine what proportion of these patients remained SRT eligible. Mavacamten is trying to put Bill and other surgeons out of business. So these patients all not only had a significant resting gradient, but had NYHA 3 or 4 symptoms. Once again, there was the ability to dose titrate at 8 and 12 weeks, and the study was conducted in 19 American centers. We see a similar mean age of approximately 60 and relatively good balance between women and men. Patients could be on medical therapy, inclusive of beta blockade, calcium channel blockade, and disopyramide, or any combination of those medications. And again, we see mean resting gradient quite significantly elevated over 50 and exercise gradient over 80. And the results here after 16 weeks of therapy, really quite amazingly, only 18% of patients in the mavacamten group remained SRT eligible. So really quite impressive compared to 77% in the placebo arm. And when they examined how many of the patients actually had an improvement in NYHA classification, we see that 63% had at least 1 grade improvement, 27% had a 2 or greater, and that's in the mavacamten arm. We see much lower rates, unfortunately, in the placebo arm. And once again, when we look at the resting gradient in blue here, we have the mavacamten arm versus the placebo arm. We see very similar results to EXPLORER. Early separation, early reduction within 4 weeks of the gradient that's sustained throughout the course of study therapy with very little clinically significant reduction in the overall ejection fraction. And once again, serum NT-proBNP levels really mirroring the results of EXPLORER and the reductions in the resting gradient. Fortunately, similar to the EXPLORER study, there were very few adverse events. There was only 1 patient who developed an ejection fraction of lower than 30% in the context of new atrial fibrillation. But fortunately, this patient had complete LVF recovery after treatment of the atrial fibrillation and discontinuation of mavacamten. So I just want to highlight that there are a few ongoing clinical studies as well in the UofC LIBIN hypertrophic cardiomyopathy clinic. We are part of the CIHR funded Hyro HCM study that's being led by Rafik Tedros out of Montreal Heart. This is a careful genetic, clinical, and imaging characterization to actually create a Canadian HCM registry to have a better understanding of our local patients. We just received REB approval for the Odyssey HCM study, which is sponsored by BMS. And this is a randomized prospective placebo-controlled study of mavacamten in non-obstructive patients who are symptomatic. And the primary endpoints are going to be clinical and cardiopulmonary exercise testing. There are two more future studies that we're hopeful to be involved with. One is the MAPLE HCM study, which is another direct myosin inhibitor, aficamten versus metoprolol in obstructive disease. And the study I'm most excited for, which is the Memento HCM study, which is a primarily MRI-based study looking at changes in hypertrophy and fibrosis after 6 to 12 months of therapy with mavacamten. Okay, I've already taken up too much time, so with that, I'll pass it over to Dr. Kent.
So yes, let's turn to surgery as the next step along the continuum of treatment for patients with hypertrophic obstructive cardiomyopathy. So we'll talk about the indications, surgical approaches, some of them novel. This is operations for HOCM have been around for a very long time, but there are some recent developments, and then we'll look at outcomes from surgery. And as you heard, pretty remarkable, outcomes with mavacamten. I've been told I'm out of business before from guys like Michael Curtis over here. But cardiac surgery is still around, and that's going to be the case with HOCM as well. So I got to say, one of the most rewarding things about working in hypertrophic cardiomyopathy is the colleagues that you work with and the team. As Bobby alluded to, it's a good group of people. It's I get to work with EPs and cath lab, and Bobby's been a great colleague, and Grant as well. It is rewarding. Surgical indications, symptoms. So as with a lot of things, surgery is last line of defense. It's when medical management has failed, and patients with dynamic LVOT obstruction, resting or provoked gradient greater than 50. Relative indications, LVOT obstruction with left atrial enlargement, onset of AFib, pulmonary hypertension. Children who have a high gradient, so like over 100 you'd look at for surgery, or a strong family history of cardiac. That's from the recent guidelines in 2020. If you have patients with symptoms and a resting gradient that's less than 30, then going to provocative measures should be used, Valsalva, stress echo, and taking them to the cath lab and seeing if you can. Certainly, Bobby talked about the MRI, really useful test, and I find this very helpful for planning the surgery. And one of the great things is we meet as a group and we look at the MRI, patients, and the anatomy is really important. It helps me guide where we're going to make the resection. It also helps a lot in planning the operation. So one operation and this is true with lots of aspects of cardiac surgery, the operation has to be tailored to the patient. So the MRI really, really helps with that. Tells about the distribution of the hypertrophy, talks about how much fibrosis is there. And what's particularly important is the mitral valve. And I think we've realized that, you often have to address the mitral valve when you're talking about surgery for We have to talk about the septal thickness. How important is that? Well, really, it's not that important for clinical decision-making. If it's mild, kind of in the range of 12 to 15, moderate 15 to 30, and severe if it's over 30. I mean, we talk about that, but in terms of, the symptoms and the gradient are more important, and the anatomy and MRI, and seeing if you can really target the area that's going to provide a symptomatic benefit for the patient. I spent a lot of time actually measuring what's the ideal amount of resection that I want beforehand. And I do that on the MRI and in the operating room with the transesophageal echo and my anesthetic colleagues, and we sort of measure. So if I take, 10 millimeters off thickness, how far down in the ventricle do I have to go? And typically you take about, 10 to 15 millimeters thickness and then extend it down. The operation for HOCM was initially called the Morrow procedure, and it's now more commonly called extended septal myectomy. And that's because the focus we've realized is you have to get deep down into the ventricle. A lot of patients have thickness of the septum that extends down into the mid cavity level. And the ones that fail, or the ones that don't do as well, are because they have a residual tissue in the mid cavity. So extended septal myectomy is what we talk about as surgeons, and that emphasizes the point of having to resect deep down. The operation itself, the approach is through the aortic valve. The right coronary cusp is at the top there. So you got to reflect the aortic valve leaflets, and it's a delicate operation. You have to move the leaflets out of the way and avoid cutting them with a knife, obviously. So we use retractors to, that exposes the septum. Now, in that picture, there's, you can see the red muscle of the septum, and there's a white fibrotic layer, and that's from trauma from the mitral valve hitting the septum. So you always see that. And so, that's always very helpful. You have to resect that portion of the septum. The challenge, of course, is getting deep down into the cavity. Now there's the resection. Now you'll see on the right side of the screen that not all of the septum is resected there. And that's because I don't want to give too much business to fish, because as you know, the conduction system is in that territory. So we start the resection right underneath the ostium of the right coronary artery, and then you continue it over to the trigone of the mitral valve, the posteromedial commissure. So that portion of septum has to be preserved if we want to avoid heart block. And often, on the post-op echo in the operating room, the anesthesiologist will give me a cut through that portion of the septum where I don't take anything, and it's like, oh my God, I've been here, I haven't done anything. But it's all, you create that kind of trough, and what's important, of course, is the gradient. So there are certainly complications that as surgeons we're all very conscious of. First of those is getting persistent LVT obstruction. So if in the operating room I've got a gradient that's more than 10 to 15, not too happy with that. If we're reading greater than 20, then I'd go back on bypass and take more muscle. Can't really accept that. So that's what we try to achieve in the OR. There is, of course, the risk of ventricular septal defect, about a 1% risk of that. And, again, it's sort of understanding the anatomy and knowing how much you can resect based on the imaging beforehand, which lets me minimize that risk. Complete heart block, really fairly low, 1% risk of that. But if you have a right bundle branch, certainly much higher. So let's look at outcomes. First of all, what's the mortality? So this is large series, major centers, Mayo Clinic, Cleveland Clinic, do the largest volume in North America by a long shot. Toronto General's on this list, and Mount Sinai. So when you look at these, and admittedly, these are experienced centers, but the operative mortality is very low. So we're looking at a, less than 1% perioperative mortality in experienced centers with this operation. So that's the first point, like a really, really safe option for patients when they become so symptomatic. Looking at the, difference in outcome between surgical septal ablation versus alcohol septal ablation. This is a contemporary study looking at 4,000 patients. Again, in this large study, 0.3% risk of perioperative mortality with myectomy. So again, demonstrating the safety of this procedure. Basically, the alcohol septal ablation also safe, generally done in a higher risk patient population. And so when you look at long-term survival, when it's adjusted, fairly comparable, but generally better long-term outcomes with surgery. And really, after a myectomy, their long-term outcomes are comparable to age-matched general population. So, it is a really good long-term outcome. Now, patients always ask me this, well, what's the chance of growing back? What's the chance of me having to have this done again? It's pretty low. Doesn't happen very often. This large series looked at that. About a 1% risk of recurrent symptoms requiring reoperation. So it doesn't happen often. I have done it once in my career, but it's pretty rare. And usually when they looked at it, it's a failure to extend the dissection deep enough down into the cavity is the most common anatomic reason. So when you compare septal ablation, alcohol septal ablation versus septal myectomy, looking at a meta-analysis, systematic review, 20 studies, no mortality difference between the two, reduction of the LVOT pressure gradients, usually better after surgery, and the risk of a pacemaker is less. So all comers surgery, about 4% risk. After septal ablation, it's high. So to summarize the results of the surgical approach, mortality is very low, symptom benefit highly, it's a rewarding procedure because patients feel better. Can lead to reduction in left atrial size, LV reverse remodeling, less arrhythmia, long-term survival similar to age-matched general population. So it's rewarding to operate on these patients. Now let's talk about, in the last couple of minutes, some of the more novel approaches. We have more of a realization that we need to address the mitral valve, certainly in some patients, and systolic anterior motion of the mitral valve is the reason for that. For those of you that aren't so familiar with that, when you have a obstruction at the LVOT and you have high velocity flow through there, there's a Venturi effect, which drags the anterior leaflet of the mitral valve into the LVOT, causing MR. So one simple way to address that is an Alfieri stitch and creating a single orifice mitral valve into a double orifice valve. Now, what this does in the case of HOCM is it sort of pins the anterior leaflet out of the LVOT, so it can't be dragged in there by the Venturi effect. It's done fairly simply through the LVOT, so you're there anyway, resecting septum. You can go down to the mitral valve. And this is a picture from the operating room showing that. Okay, there's a stitch in the anterior leaflet of the mitral valve. You can see the anterior mitral valve leaflet, posterior is behind it, and there's the pap muscles and the chordal apparatus. So by doing that, you can see the stitch there, the little blue stitch that's sort of holding the leaflets out of the way. Now, stenosis is an incredibly rare complication when you put a stitch in a normal. That's not really a concern, creating it to a double orifice valve. We've looked at our results, both when I trained in Chicago and here in Calgary, reducing mitral regurgitation associated with SAM, very effective for that. Over time, this is only 2-year follow-up, but freedom from 3 to 4 plus MR, very good, medium result over time. So it's effective. The benefit from septal myectomy and low LVOT gradient also sustained. And certain patients really need this done. And those, this simple diagram, it's simple to understand. Again, drawing after you've resected septum, which patients are at risk for having ongoing SAM, or when's that going to be an issue post-operatively? Well, if the coaptation line is more anterior, closer to the LVOT, that's the concern. And what you really want is you want a long length of coaptation posteriorly that's going to give you low risk of post-op SAM. So the patients with the anterior line of coaptation are the ones you really want to treat surgically. Some other approaches, you can actually go through the mitral valve to address the septum. Patients are ones that have thickened septum further down into the cavity. This is a select group, but we do this. This is allows you to address both the mitral valve and the septum as well. So I can show you a video of like two of the approaches here. First of all, like full disclosure, this is sped up. I mean, for me to do a sternotomy and film that for you, we'd be sitting here for 20 minutes, kind of boring. So this is all sped up. So this would be, you know, conventional septal myectomy, extended septal myectomy, pericardium opened. It's a hard, really hard surgery to teach because exposure is tough. I mean, exposing the aortic valve to teach resonance is difficult, and then you're going below. So that retractor is going below the leaflets and pulling the leaflets out of the way. So you're down to the septum below. So, it's something that, teaching residents this, you got to move them around and show them how much you're resecting. It's a real field. This is a video from, and this is actually Andrew Maitland and he taught me a lot about how to do this type of surgery. And so this is him operating. I filmed this case. This is resecting the septum through the anterior leaflet of the mitral valve. So the mitral valve has been opened at the level of the annulus and reflected. So you can see through and you can see the septum. That's a typical resection. Looks pretty small, and you pull it out and you think, geez, all this work for that? Is that really going to help? But it's dramatic, the symptom benefit. Now, this patient actually had what I was telling you about, the anterior line of coaptation. We really wanted to move the coaptation line posteriorly. So that involved some repair of the mitral valve leaflet work as well. In order to move the coaptation line posteriorly, we augmented the anterior leaflet. So this is a bovine pericardial patch, and this is sewn into the tract where the resection was taken through. So this is like anterior annulus of the mitral valve, bovine pericardium being sewn in there. And by doing this, that increases the size of the anterior mitral valve leaflet, results in coaptation more posterior and much lower risk of. Again, Andrew didn't operate this fast. This is sped up. Quick surgeon, but not. So again, this is the leaflet margin is a little further down there, and then you tie this. Now, whenever you repair the mitral valve, you kind of support the repair with an annuloplasty, and you're going to see that in a second. There's a partial annuloplasty. We baleen into the ventricle to make sure it's competent, and competent valve certainly achieved. That's the approach that allows you to see intraoperatively what it looks like. That would be sort of for select patients with hypertrophied septum, which extended down into the cavity more. Now, another approach is, I just mentioned this because we've had a couple really good successes with this, and approach done only at the Mayo Clinic by a surgeon named Hartzell-Schaff. Rather than going through the aortic valve to address the septum, he also, and he sometimes does it together, he'll go through the LV apex and resect part of the septum through the apex through a ventriculotomy to achieve, it's called the ice cream scoop. Bold, but it can have a dramatic effect and benefit for patients that otherwise might be, transplant candidates. So to conclude with 10 minutes for questions, septomectomy reserved for patients who remain asymptomatic, that remain symptomatic despite medical therapy, including mavacamten. And so excellent results, but we are still the last line of defense here. So surgery is the option with failure. important to know mectomy operation is safe, highly effective, and durable. And final point is a team approach is necessary to guide surgical decision-making. That's focused on in the guidelines, and I think we have the luxury of having that here in Calgary. Thanks very much.
So that's great. I'll have Bobby come up here and we're open to questions. I'm not sure I can see them via Zoom. We'll work on that. Before I let you guys ask questions in the room, I just want to remind you that this is a CME Royal College accredited session, but no evaluation, no credit. So in the invitation, there was a link. Please fill it out. I think you have 7 days, and then Kelly gets upset and takes it down, and no credit again. Any questions in the room? Get you guys to come over here. Just so we have a question online. Is regarding Bobby's favorite new drug. I guess the question is this a short-term give lots of money for a short period of time drug, or is this a give lots of money for the rest of their life type of drug? And you can't answer the question unless you come over here and speak into the microphone.
Yeah, thanks. So that's a great question. I think Stephen Myers asked that question. So I just want to make a few comments. So the first thing is I was joking around a little bit about mavacamten trying to put Bill out of business, but you know, there is a substantial, and I think Grant would attest to this as well, there's a substantial heterogeneity of disease in HCM. So we do see a lot of young patients or middle-aged patients who have very, very severe degrees of hypertrophy and are extremely symptom limited. And I think the likelihood of medical therapy, even with mavacamten achieving, you know, a result that substantially improves their quality of life is very low. You know, interestingly, I've had an opportunity to sort of speak to folks around Canada at the various different HCM centers, and you know, two concepts have really been highlighted to me. The first is that an HCM multidisciplinary center really needs a myectomy surgeon. And unfortunately, there are very few myectomy surgeons across Canada. We're actually very lucky here in Calgary to have Bill, with you know, no joking aside, for our patients. And the second issue is that even in the case of alcohol septal ablation, there's a very big program that Ben Tyrell runs over at the Royal Alex in Edmonton. Really, they only apply that to patients who have moderate or milder degrees of hypertrophy. When patients have very severe degrees of hypertrophy, they're actually not really amenable to alcohol septal ablation in their experience. And they're one of the highest volume centers in Canada. So I think, you know, the importance of myectomy is there, and it is really still the standard of care. How long will patients need to be on mavacamten? Well, that's a great question, Stephen. The answer is we don't know. We do have some, which I didn't present, we do have some data from the extension EXPLORER study, which was essentially keeping patients on mavacamten for 96 weeks or greater. And there is a MR sub-study that I'm involved with extension. And what we see is that the gradient remains low. As long as the patients are still on mavacamten, they seem to have, you know, good results. So this could be a lifelong therapy. Now, fortunately, there are a few adverse events. In terms of cost, I'm not sure. I don't think those numbers are really well flushed out yet. But it is something that we will see, and I'm sure there will be some cost effectiveness analyses coming down the pipeline.
So for those online, just Graham Peters made 2 points. One is that in younger patients, especially, cost becomes a big issue, and that's sometimes a reason to go to surgery earlier rather than later. But the other big bit of information that might affect that is whether it's truly a disease modifying drug or if it's more useful when used drug. Great. I think we're almost at the top of the hour. I'd like to thank both Bobby and Bill for presenting today. I love the GoPro shots of cardiac surgery. Look forward to more of those. Thank you all for coming out. Sign off or?